You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
What is serotonin syndrome? Serotonin syndrome is a potentially life-threatening adverse drug reaction caused by too much serotonin activity in the central and peripheral nervous system. It is not an allergy, not an idiosyncratic reaction. It is a predictable, dose-related toxicity that happens when serotonin levels overwhelm the brain's ability to regulate them. The classic triad is mental status changes, autonomic instability, and neuromuscular hyperexcitability. The good news? It is almost always preventable if you know which drug combinations to avoid, and it typically resolves within 24 hours once the offending drugs are stopped. How serotonin works. The 60-second pharmacology lesson. Serotonin 5-HT is made from the amino acid L-tryptophan inside presynaptic neurons in the brainstem RAF nuclei. Once made, it's packaged into vesicles, released into the synapse, and then either reabsorbed back into the presynaptic neuron by the serotonin transporter SERT, or broken down by the enzyme monoamine oxidase A, MAO-A, into its waste product, 5-HIAA. This system is tightly regulated, like a thermostat keeping the temperature just right. Serotonin syndrome happens when drugs break the thermostat by flooding the synapse with serotonin faster than the brain can clear it. The key receptor driving the syndrome is the 5-HT2A receptor. Overstimulation of this receptor is what produces the dangerous neuromuscular and hyperthermic features. The 5-HT1A receptor also contributes, especially when serotonin concentrations are high enough to saturate all receptor subtypes. The serotonin drug lineup. Know your offenders. Think of serotonin-boosting drugs in 5 categories based on how they increase serotonin. This is the key to understanding which combinations are dangerous. Category 1. Block reuptake, SERT inhibitors. These drugs block the serotonin transporter, so serotonin can't get vacuumed back into the presynaptic neuron. This is the largest category and includes SSRIs, fluoxetine, sertraline, paroxetine, citalopram, escitalopram, fluvoxamine, SNRIs, venlafaxine, desvenlafaxine, duloxetine, TCAs, especially clomipramine, amitriptyline, and here's where the exam traps live: tramadol, meperidine, demerol, methadone, dextromethorphan in cough syrup, and tapentadol. These opioids are not just pain drugs, they are potent SERT inhibitors. Category 2, block breakdown, MAO inhibitors. These drugs block monoamine oxidase, the enzyme that destroys serotonin. With MAO blocked, serotonin accumulates to dangerous levels. This category includes the classic MAOIs, phenelzine, tranylcypromine, isocarboxazid, selegiline, and the sneaky ones the exam loves, linezolid, the antibiotic. It's a reversible, non-selective MAO inhibitor, an IV methylene blue used for methemoglobinemia. It's a potent, reversible MAO inhibitor. These two are the number 1 and number 2 most commonly missed serotonin syndrome triggers on board exams. Category 3, increase serotonin release. These drugs push serotonin out of the presynaptic neuron into the synapse. This includes MDMA, ecstasy, amphetamines, and fentanyl, which causes serotonin efflux and also binds 5-HT receptors directly. Category 4. Direct receptor agonists. These drugs directly stimulate serotonin receptors. This includes triptans, sumatriptan, rizatriptan. They hit 5-HT1B/1D receptors, buspirone, 5-HT1A, partial agonist, and LSD. Category 5. Increase serotonin precursor. L-tryptophan and 5-HTP supplements increase serotonin synthesis by providing more raw material. Herbal offender, St. John's wort, acts as both a serotonin reuptake inhibitor and a weak MAO inhibitor. Double trouble. The deadly combinations. What triggers serotonin syndrome? The most dangerous combination is MAOI plus SSRI/SNRI. This is the classic lethal pairing. Blocking both breakdown and reuptake simultaneously causes a massive serotonin surge. The FDAFA-ERS database shows MAO inhibitors have the highest reporting odds ratio for serotonin syndrome, followed by SSRIs, but the exam loves to test the sneaky combinations that clinicians miss in real practice, that didn't see it coming. Combos. SSRI plus tramadol. Tramadol is an opioid and a SERT inhibitor. Patients get prescribed tramadol for pain without anyone checking their antidepressant list. SSRI plus linezolid. Patient gets admitted for an infection. ID starts linezolid. Nobody checks the med list. Linezolid is a reversible MAO inhibitor. SSRI plus IV methylene blue. Patient on an SSRI goes to surgery, develops methemoglobinemia, gets IV methylene blue, a potent MAO inhibitor. Serotonin syndrome develops in the OR, SSRI plus dextromethorphan. Patient with depression buys OTC cough syrup containing DXM. DXM is a potent SERT inhibitor, SSRI plus St. John's wort. Patient starts the herbal supplement on a friend's recommendation without telling their provider. SSRI plus fentanyl. Perioperative period is high risk. Patient on an SSRI receives fentanyl for anesthesia. SSRI plus meperidine. Demerol. Meperidine is the opioid with the strongest SERT inhibition. This combination has caused fatalities. The washout rules. How long to wait between serotonergic drugs. This is heavily tested on boards. The washout period depends on the drug's half-life. Stopping an MAOI leads to starting an SSRI/SNRI. Wait at least 14 days. MAO enzyme needs to regenerate. Stopping most SSR leads to starting an MAOI. Wait at least 14 days. Stopping fluoxetine leads to starting an MAOI. Wait at least 5 weeks because fluoxetine's active metabolite norfluoxetine has a half-life of 4 to 16 days, the longest of any SSRI. Stopping an MAOI leads to starting fluoxetine. Wait at least 14 days. Memory trick. Fluoxetine equals 5 weeks equals forever compared to other SSRIs. Every other SSRI is 14 days. Fluoxetine is the outlier because of norfluoxetine. The Hunter criteria. How to diagnose serotonin syndrome. The Hunter serotonin toxicity criteria are the gold standard for diagnosis. They are simpler, more sensitive, 84%, and more specific, 97%, than the older Sternbach criteria. There is no lab test that confirms serotonin syndrome. It is a clinical diagnosis based on history and physical exam. Step 1. Has the patient taken a serotonergic drug? If no, it's not serotonin syndrome. If yes, proceed to Step 2. Step 2. Does the patient have any one of the following 5 findings? Spontaneous clonus, rhythmic, involuntary muscle contractions happening on their own, especially ankle clonus. This alone equals serotonin syndrome. Done. Inducible clonus plus agitation, diaphoresis. You dorsiflex the ankle and clonus is triggered, and the patient is agitated or sweating. Ocular clonus plus agitation, diaphoresis, slow, continuous horizontal eye movements, like a pendulum, and agitation or sweating. Tremor plus hyperreflexia, shaking plus exaggerated deep tendon reflexes. Hypertonia plus temperature greater than 38 degrees Celsius, 100.4 degrees Fahrenheit, plus ocular clonus or inducible clonus. This is the severe life-threatening presentation. The single most important finding is clonus. It is the most specific and sensitive sign. If you see clonus in a patient on serotonergic drugs, think serotonin syndrome first. Memory trick: clonus is central to serotonin syndrome. No clonus? Think about other diagnoses. NMS, anticholinergic toxicity, malignant hyperthermia. The severity spectrum: mild, moderate, and severe. Serotonin syndrome is not all or nothing. It exists on a spectrum from mild to life-threatening. Mild: hyperreflexia, tremor, diaphoresis, mydriasis, dilated pupils, tachycardia, diarrhea. Patient is alert and oriented. This is the most common presentation and often goes unrecognized because the symptoms look like anxiety or medication side effects. Moderate: all of the above plus clonus, spontaneous or inducible, agitation, ocular clonus, hyperthermia, temperature up to 40 degrees Celsius, hyperactive bowel sounds. Patient is restless and uncomfortable. Severe: all of the above plus temperature greater than 41.1 degrees Celsius, 106 degrees Fahrenheit. Severe muscle rigidity, which can mask the clonus and hyperreflexia. Exam trap: seizures, rhabdomyolysis, metabolic acidosis, DIC, multi-organ failure, and death. This is a medical emergency requiring ICU care. Bored pearl: in severe serotonin syndrome, the muscle rigidity can become so intense that it masks the clonus and hyperreflexia, making it look like NMS. The NEJM review specifically warns that muscle rigidity may mask the highly distinguishing findings of clonus and hyperreflexia and therefore cloud the diagnosis. This is why medication history is critical. If the patient is on serotonergic drugs, not antipsychotics, think serotonin syndrome even if rigidity is prominent. Serotonin syndrome versus NMS. The board exam showdown. Quick review. Serotonin syndrome, caused by serotonin excess. Onset in hours. Clonus plus hyperreflexia plus myoclonus. Dilated pupils. Hyperactive bowel sounds. Diarrhea. Mild to moderate CK elevation. Skin is diaphoretic, wet. Think twitchy and fast. NMS, caused by dopamine blockade, onset over days, lead pipe rigidity, normal or decreased reflexes, no clonus, normal pupils, decreased bowel sounds, massively elevated CK. Skin is diaphoretic but can be pale. Think rigid and slow. The one finding that separates them: clonus. Clonus equals serotonin syndrome. No clonus plus lead pipe rigidity equals NMS. Treatment protocol: the step-by-step approach. Step 1. Stop all serotonergic drugs immediately. This is the single most important intervention. Most mild to moderate cases resolve within 24 hours after drug discontinuation. However, drugs with long half-lives, fluoxetine, or active metabolites may cause symptoms to persist longer. Step 2. Supportive care. IV fluids for hydration, continuous cardiac monitoring, correct electrolyte abnormalities, monitor temperature closely. Step 3. Benzodiazepines for agitation. Benzodiazepines, lorazepam, diazepam, are essential regardless of severity. They reduce agitation, lower heart rate and blood pressure, and decrease muscle activity, which helps with hypothermia. Do not use physical restraints. They force isometric muscle contractions that worsen lactic acidosis and hypothermia and have been associated with increased mortality. Step 4. Cyproheptadine, the antidote. Cyproheptadine is a 5-HT2A receptor antagonist. It blocks the exact receptor driving the syndrome. The NEJM recommends the following dosing protocol: initial dose of 12 milligrams, then 2 milligrams every 2 hours if symptoms continue, up to a total of 12 to 32 milligrams in 24 hours. This dose binds 85 to 95% of serotonin receptors. Maintenance dosing is 8 milligrams every 6 hours once symptoms are controlled. Important caveats: cyproheptadine is available only in oral form. Tablets can be crushed and given via NG tube. It causes sedation, which can actually be helpful, and its efficacy has not been rigorously established in controlled trials, but it remains the recommended specific therapy. Step 5. Control autonomic instability. For hypertension, especially from MAOI interactions, use direct-acting sympathomimetics, norepinephrine, phenylephrine, epinephrine, not indirect agents like dopamine. Why? Indirect agents like dopamine are metabolized to norepinephrine and epinephrine intracellularly. Normally, MAO limits these metabolites, but if MAO is inhibited, the intracellular concentration of these metabolites skyrockets, causing a dangerous, exaggerated hemodynamic response. For hypertension and tachycardia, use short-acting agents like nitroprusside and esmolol. Step 6. Control hypothermia, severe cases. If temperature exceeds 41.1 degrees Celsius, 106 degrees Fahrenheit, the patient needs immediate sedation, neuromuscular paralysis, with a non-depolarizing agent like rocuronium, and orotracheal intubation. The hypothermia in serotonin syndrome is caused by excessive muscle activity, not by a hypothalamic set point change. So, antipyretics, acetaminophen, NSAIDs do not work. You must stop the muscles from generating heat. This is a critical exam point. Alternative specific therapy. If a parenteral serotonin antagonist is needed, cyproheptadine is oral only. Chlorpromazine 50 to 100 mg IM can be considered. It has 5-HT2A antagonist activity. Sublingual olanzapine 10 mg has also been used successfully, though evidence is limited. The master mnemonic: shivers S, shivering H, hyperreflexia and hypothermia D, increased temperature, increased heart rate V, vital sign instability E, encephalopathy, confusion, agitation R, restlessness S, sweating and spontaneous clonus, the sneaky serotonin drugs. The ones everyone forgets. These are the drugs that cause serotonin syndrome but don't look like serotonin drugs at first glance. The exam loves these. Linezolid, it's an antibiotic, oxazolidinone class, but it's also a reversible, non-selective MAO inhibitor. A JAMA Network open study found that concomitant use of linezolid with antidepressants significantly increases serotonin syndrome risk. IV methylene blue, used for methemoglobinemia, but it's a potent, reversible MAO inhibitor. The FDA specifically warns against using it in patients on serotonergic drugs. Tramadol, it's an opioid, but it's also one of the strongest SERT inhibitors among all opioids. It also directly releases serotonin. Dextromethorphan, DXM, found in OTC cough syrups. Robitussin DM, NyQuil. It's a potent SERT inhibitor, also found in the prescription drug Ovaliti, DXM plus bupropion for depression, meperidine, Demerol, the opioid with the strongest SERT inhibition. Absolutely contraindicated with MAOIs. Fentanyl causes serotonin efflux and binds 5-HT receptors directly. Perioperative risk in patients on SSR is St. John's wort, herbal supplement that acts as both a SERT inhibitor and a weak MAO inhibitor. Methadone, SERT inhibitor plus 5-HT receptor binding. Safe opioids. Minimal serotonin risk. Morphine, hydromorphone, hydrocodone, oxymorphone, codeine. These do not significantly inhibit SERT. Quick fire review. The 10 things you must know for boards. Serotonin syndrome develops in hours, not days like NMS. The key receptor is 5-HT2A. That's why cyproheptadine, a 5-HT2A antagonist, is the antidote. Clonus is the single most important diagnostic finding, spontaneous, inducible, or ocular. The Hunter criteria are the gold standard. 84% sensitive, 97% specific. The most dangerous combination is MAOI plus SSRI. But Linezolid, IV methylene blue, tramadol, and DXM are the sneaky triggers. Fluoxetine requires a 5-week washout before starting an MAOI. All other SSR is equals 14 days. Cyproheptadine dosing, 12 milligrams initial to 2 milligrams every 2 hours to maintenance 8 milligrams every 6 hours. Maximum 32 milligrams per 24 hours. Antipyretics don't work for serotonin syndrome hyperthermia. The heat comes from muscles. No.
Thanks for watching. Like and subscribe for more content. Thanks for watching. Like and subscribe for more content.